Welcome to Season 4 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Commissioner of Health in Baltimore City. Our goal is to bring scientific evidence and experience to current topics in public health through engaging interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, listeners. I'm Lindsay Smith Rogers, producer of Public Health on Call. Since March 3rd, 2020, Public Health on Call has brought you more than 400 episodes with evidence and experts to help unpack the day's COVID-19 and public health news and what it means for tomorrow. As we wind down Season 4, we have a few thank yous. First, a big thank you to our interns, Kelly Corcoran, Caroline Wang, Alyssa Tsu, and Hannah Bennett, who bring fresh ideas and much-needed support for the podcast. We'd also like to thank you, our listeners, for sharing your ideas and questions and for downloading this podcast more than 6 million times. We're taking a break starting December 23rd, and we'll be back on January 3rd with Season 5 of Public Health on Call. We'll continue to cover the latest on COVID vaccines, treatment breakthroughs, and research. We'll talk about living with COVID and what our world might look like going forward as we move from pandemic crisis to endemic virus. We'll also cover other urgent public health issues, including racism, gun violence, mental health, climate change, and overdose. We so appreciate all the great ideas that come from our listeners, so please keep writing us at publichealthquestion@jhu.edu. And thank you for being part of this podcast.
Today, a terrific conversation on Omicron, featuring one of the leading researchers in South Africa, Dr. Glenda Gray. Dr. Gray is the president and CEO of the South African Medical Research Council, equivalent to the National Institutes of Health here in the United States. She's also a vaccine researcher. Joining Dr. Gray is Dr. Chris Beyrer, the Desmond M. Tutu Professor of Public Health and Human Rights at Johns Hopkins, who works extensively in South Africa. I had the chance to ask Dr. Gray and Dr. Beyrer about how Omicron was discovered, how it's behaving, and what it means for South Africa and the world. Let's listen. Dr. Gray and Dr. Beyrer, thank you so much for joining me on Public Health on Call. I want to start with my first question to you, Dr. Gray. We've been reading a lot about Omicron, and recognition of this variant started in South Africa. How did that happen?
Yes, so it's true that it first started in South Africa, and it was identified in an area in South Africa near Johannesburg and Pretoria, where a private laboratory that do routine PCR testing picked up on one of their tests that there was what we call an S-target gene failure, which means that they were getting an anomaly in their testing strategy. And this seemed to continue. And it wasn't just one or two tests, but a number of tests. And so they were concerned about this finding and notified the virologist to do surveillance in our country and sent the samples across for sequencing. And when they sequenced this virus, they found that this was a virus that had a lot of mutations, a lot of deletions, and then started to look further. We had been monitoring the genetic structure of the SARS-CoV-2 virus because we are concerned about variants of concern, and we were watching this variant that was circulating at a low grade in South Africa, and there was a worry that this variant might take off. So this came as a big surprise, this new variant. And very quickly, we saw it rapidly become the predominant, in over a 2-week period, become the predominant variant circulating in the Gauteng area where Johannesburg and Pretoria is. Initially, we thought it was a breakout amongst some university students, and this turned to not be true. It wasn't a breakout, but actually there was community transmission, and it has fueled the wave that we have in South Africa at the moment.
Got it. Now, you just described a pretty robust public health system for identifying a signal and then being able to really investigate it. I wonder, Dr. Beyrer, what this speaks to about South Africa's capacity. I know you have been doing a lot of work in and with South Africa.
Well, I think the first thing to say is we're all deeply in the debt of the South African scientists and public health system because, they identified this early. And as we know, in pandemics, time really matters. I think one of the things that's important to say is that there's been a longstanding, now more than 20-year collaborative investment, principally around HIV, but also TB and other conditions, clinical trials, infrastructure, laboratory infrastructure, that has really, made South Africa just a critical scientific partner in collaborative research and vaccine trials. And that is really paying off in their ability to do molecular surveillance, pick up new variants of COVID, sequence them, and really understand at a population level as well the epidemiology, the emerging epidemiology, which is critically important because this is a virus that interacts with populations. And so we need to understand the virus, and we also need to really understand the epidemiology of the populations. I think that's something that South Africa has been doing a really remarkable job with.
Well, you're making an important point, which is that it wasn't just the identification of the variant, but South Africa is leading in understanding the variant. And Dr. Gray, I wonder if you could tell us what you've learned since the identification, what kinds of, surveillance, monitoring, and understanding has resulted.
Sure. I think the first time the virologists had a look at the new variant, they were horrified because it had a lot of mutations. And there was a lot of fear that we were looking at a beta variant of concern. And there was a lot of concern about how this virus works against the vaccines that we have in the country. And so there was a lot of concern. And that is why the scientists raised the alarm to alert our country, our president and our Minister of Health that there was this new variant, and also publicly shared this with WHO and the international community. So the first thing was, look, we found this variant and we're concerned and we want you all to know about it. And so I think that was the most important thing. And then the second thing is then we have wonderful teams. We have hospital surveillance teams. We have genetic surveillance teams. And we also have teams that are monitoring vaccine effectiveness. So we were all able to work together as scientists to bring together all the information. We had modeling teams who were modeling the reproductive rate. And so just the collaboration between all the scientists in South Africa has been phenomenal. We've all worked together and there's no competition to try and answer all the questions, not only for South Africa, but for the global community. We've held regular meetings with the NIH to give them up-to-date information on what's happening in South Africa. We've rapidly worked with institutions to try and establish vaccine effectiveness to see whether we need to bring in boosters more frequent and more earlier than we had anticipated. And so there's a good collaboration and also with our ministry. So the last 2 years have taught us also to work well with our politicians and our ministry to try and work together for the best of the country.
Got it. So tell me more about what you have found through that collaboration. How worried should we be about Omicron?
Well, in South Africa, what we're seeing is what we call an uncoupling or delinking of cases from hospital admissions. So normally, if we look at Delta, the Delta variant of concern, the hospitalization rate kind of mirrored and was linked closely to the case rate, and it followed. And when we look at the Omicron surge, there's a delinking in that we have a lot more cases in comparison to hospital admissions. So an uncoupling or delinking of the cases with the admissions. So that's an interesting finding. And so what we're seeing is that in South Africa, there's less hospital admissions, less deaths, and less severe disease. In fact, that ICUs are under control. We haven't had to put a person onto ECMO at the moment. And most of the people who are being admitted to the general wards. The hospital stay is very short, 2.5 days. It's much shorter than we'd seen before. And a lot of younger people are in hospital. But I also need to emphasize that 2/3 of the hospital admissions are in the unvaccinated group. So what does this tell us? It tells us that maybe prior exposure to SARS-CoV-2, either in the Delta or in the Beta or the original surge, may confer some cross-variant protection. And then in that, together with a moderate vaccine coverage rate, may be giving us this disease spectrum. But we don't want to speculate on the virulence yet because we're not sure how this virus will perform in areas where there's very low vaccine coverage or in areas where you've managed to keep SARS-CoV-2 out, like, say, New Zealand or Australia, where there's very, very little background seroprevalence or a background positivity of in the previous exposure to SARS-CoV-2.
So, in other words, Omicron has spread very rapidly, but it has not put the kind of pressure on the South African healthcare system that, say, the Delta variant did in India, South Africa, other countries.
Yes, if we look at the amounts of cases we have and we compare that to when we had Delta, there were just so many more hospital admissions, so much pressure. We had cases in Delta where people were waiting in their cars outside the hospital, waiting for oxygen, and waiting in ambulances in the parking lots of hospitals. People, not enough ICU beds, not enough ECMO machines. And so I think what we have is a completely, an uncoupling, as I would say, of severity with the cases that we see.
Yeah. And so, Dr. Beyer, what does this tell you for the rest of the world? You heard Dr. Gray talk about the potential differences between South Africa and other countries. How do you put that together?
Well, I think one thing to say is that there's evidence that the Omicron variant is spreading in the region. And South Africa, of course, is a large country and an important place of commerce and labor and movement across that region. And the rates of immunization in a number of the neighboring countries and indeed across the continent are significantly lower than South Africa. So South African vaccine coverage is around 35%. And they have been using Johnson & Johnson and now also Pfizer, the mRNA vaccine. So they have high efficacy vaccines. We're still, for much of the rest of the continent, under 10% immunization coverage. And so, it's hard to extrapolate what you're seeing in South Africa to other countries. We'd hope that this holds and that the severity is not as marked. When you look at, the US and Europe, we're still in a Delta surge, right? Europe is really having a serious Delta surge. And of course, our hospitalizations and deaths are, we have about 1,300 a day. So we're still having this Delta surge. And of course, we have a much higher overall immunization rate. That's about 62% of all people in this country are fully vaccinated. But that still hasn't been enough to protect against Delta. And it probably means that there are still too many susceptible people for Omicron. So it could certainly spread here.
So it sounds like we are going to be waiting a little bit to really understand the full picture of how severe this is. But certainly the early signs could be worse. We could say that the early signs could be worse. Let me focus in, Dr. Gray, on a point that you made that the majority, I think you said 2/3 of the people who are hospitalized are unvaccinated. Do we have any early evidence from South Africa about the potential value of vaccination for protecting against this variant?
Yes, so we do have some preliminary information looking at, first of all, vaccine effectiveness, real-world vaccine effectiveness using the 2-dose Pfizer. And so what we have shown is that the ability of the 2-dose Pfizer to protect against infections has been reduced. But what's more important for us is how does this 2-dose Pfizer work against protecting against severe disease like hospitalization and death? And so the results we have are encouraging. Vaccine effectiveness for Pfizer is around 70% protection against hospital admission as compared to unvaccinated people, which is down from the 90% that we would like to see, but still reassuring that this variant has not completely caused a kind of null and void to vaccine effectiveness. So we're happy with the 70% vaccine effectiveness, and we believe a boost is going to help us increase the vaccine immune responses and up the vaccine effectiveness.
Let me just zero in on this question, though, because we're hearing a lot about lab studies where people are taking the antibodies from people who have been vaccinated and see whether it works against Omicron. What you're talking about, though, I think is actually what is actually happening to people in South Africa, that they're getting hospitalized less. And so that really is the full picture of the immune response, because one of the limits of those lab studies is just that they're looking at the antibodies and not other components of the immune system. You're looking at, as you said, the real world experience, and there you're seeing a pretty significant drop in hospitalization for people vaccinated with just 2 doses of the Pfizer vaccine.
Yes, so just 2 doses of the Pfizer vaccine, we're seeing still a protection against hospital admission, which is reassuring for us. We think 70% vaccine effectiveness is very reassuring. And we know that the Omicron does reduce the vaccine effectiveness against getting COVID infection. So we do see breakthrough infections, but these breakthrough infections are mild and have not translated at this stage into severe disease or death. Even if we look at our healthcare worker cohort who got the single dose J&J, we've had lots of breakthrough infections since the 15th of November. And this has not translated into a lot of hospitalizations, and we've had no deaths attributed to the Omicron variant. So we're reassured that even though the neutralizing antibodies, even though we know that there's an escape from neutralization, there are other parts of the immune system like CD4 and CD8 T cell responses that also help, that are obviously critical and are still showing that the vaccine can protect against death and hospitalization using other arms of the immune system.
Great. I'm going to be honest with you. That is the best news I have heard all week about this variant. So I really appreciate your sharing it with us. Dr. Beyer, I want to switch gears a little bit because, one of the first things that happened after the variant was identified in South Africa was that a bunch of countries announced, travel restrictions for South Africa and then a whole bunch of other countries in that region. And as we're recording this today, those travel restrictions are still in effect, even as Omicron has been identified in many, many places in the world. How do you put that together?
Yeah. Well, I think one of the things that we saw was a number of countries, and New Zealand, as Glenda mentioned earlier, certainly one of them, in the first year and a half, we're really focused on these zero COVID strategies and basically trying to use travel restrictions to prevent importation. And one of the things that we saw with Delta is that it was a significantly more infectious variant, and those strategies just didn't work and were not holding. So when the U.S. administration imposed the travel ban on the 9 Southern African countries, South Africa and its neighbors, they did so saying explicitly, this is not going to protect us from introduction of this variant. It's just to buy time. And that, has some reasonable strategy and thinking. However, of course, it failed because this is a highly contagious variant. The data is maybe around twice as contagious as Delta, which was already substantially more infectious than the earlier variants and then the original parent virus. So, we knew right away that this approach was not going to hold against this highly infectious variant. It didn't work for Delta, and it wasn't likely to work in this case. And that's exactly what's transpired. I think what we've seen repeatedly is that policymakers, decision makers, governments jump to want to look like they're doing something meaningful and to respond. And then we get stuck with these restrictions that are still in place when they really don't have any scientific relevance. This happened on the U.S.-Mexico border in 2020. The administration, said we're not allowing people to come into the United States because of the risk of importation of COVID when we were the most affected country in the world. And it's just, from a public health perspective, nonsensical. So I think, it's important to understand that these travel bans and restrictions, while they don't necessarily contain these highly infectious variants, they do have big impacts on people's economies, on people's lives. And, they are, in a sense, prolonging the economic and social impacts of the pandemic more than they are affecting really public health.
Well, thank you. And Dr. Gray, I'm curious about your perception and the perception within South Africa of how this has all transpired.
Well, I think it is devastating because there are ways of preventing transmission, and that's by getting vaccinated and doing frequent testing at the port of entry, and to make sure that the tourism interfaces of people are highly vaccinated. So I think there are better ways of managing this than closing down borders, because we were going into our December months. 3 million people have lost their jobs, mostly women. Restaurants, the tourism industry, the hotel industry has taken a severe knock, and that is jobs. That puts food on tables. And so by closing down our summer season and preventing people from coming into our country is devastating. It's devastating to our economy. It drives a huge divide in the way we feel about we've been punished for being honest and punished for alerting the world that there's something new happening. And this kind of action, may deter other scientists in other countries from being transparent with the epidemic in fear of losing this critical trade that we so badly need. And so we don't want to drive information underground. And the way you manage pandemics is by transparency and communication and information sharing. You don't manage pandemics by impeding the movement of people, because we already see that by the time you close down, as we saw in the UK, by the time they closed down the flights, there was already Omicron in the UK. And so it had no value at all.
Well, you're making the case very, very plainly. Thank you. I want to end with a final topic that I know is near and dear to both of your hearts, which is about HIV. I know both of you have worked not just on COVID, but also on HIV. And I wonder how, Dr. Gray, you see the interaction between COVID and HIV in South Africa.
So you may not know, but South Africa is heavily burdened by HIV. So we have about 8 million people who are HIV infected. And even though we have the largest antiretroviral treatment program in the world, at least a third of our HIV-infected individuals aren't on antiretrovirals, which means that they're incredibly immunocompromised. And what we've seen is that people who are HIV positive, particularly those who aren't on antiretrovirals, they're more likely to die and get hospitalized from COVID. And so they're incredibly vulnerable to COVID infection. We also know that because they're immunocompromised, we also worry about how effective vaccines will be in immunocompromised people who aren't on treatment. And so we also worry about that vaccine effectiveness will be less, particularly less likely to protect you against death. And so it's very important for us to make sure that we keep people on treatment and we get their CD4 counts up and we get them vaccinated. It's also important because we know that in South Africa, our biggest cause of immune suppression is HIV. And we do know that people who are immunosuppressed are likely to shed the virus for longer. They're likely not to mount a good immune response against the virus. And this makes the evolution of the virus more likely. And so it's very important for us to make sure that we get people onto treatment, people who know their diagnosis and they get vaccinated. We need to protect HIV-infected people from dying from COVID. And we need to use both antiretrovirals and vaccinations to do this. And we also need to make sure that we prevent the chronic shedding of the virus in people who are immunosuppressed in our country.
Thank you, Dr. Beyer. How do you see the imperative on HIV that comes out of the pandemic?
Well, Glenda's absolutely right that, it's been true and it continues to be true that for people living with HIV, getting on antiviral therapy and achieving viral suppression is fundamental to their well-being. It also reduces their risk of transmission. It is a very challenging situation to have so many people globally, but of course the highest burdens are in Africa, living with HIV and not treated. And so we really need to address that issue. And what's emerged with COVID-19, unfortunately, is that people with immunocompromise, for whatever reason, HIV is the most common reason for immunocompromise in South Africa. But of course, TB is also immunocompromising. Malnutrition is immunocompromising. All kinds of hereditary immunocompromise syndromes and diseases exist, cancer, chemotherapy. And these folks really need prioritization for COVID immunization and treatment, hopefully for the antivirals when they come, because they also, as it turns out, are at risk for not being able to clear the virus and for viral mutation then to continue in their systems. And unfortunately, this we think is very fundamental to how these new variants of concern emerge. At least for now, the data we have suggests that most, if not all, of the new variants have emerged in people with immunocompromise. And the first case of this that was picked up in the US was a man with a hereditary autoimmune disease with immunocompromise in Boston, who ended up having essentially every mutation we'd seen up till that point in the virus in his body after 150 days of continuous COVID. So for these folks also, third doses of vaccines with the 2-dose vaccines are recommended, not so much as a booster, but really to achieve full immunization. We think that people with immunocompromise really need 3 full doses. And I think, what Omicron suggests to us is that really everybody needs to get immunized who isn't vaccinated now, and that boosting is really important. And I think that is a really important take home. And if someone is living with immunocompromise or has an immunocompromised person in the home, then everybody else really needs to be fully vaccinated and boosted.
That sounds like that is great advice for individuals, but also with these policy implications about the importance of doubling down on outreach and treatment for people with HIV, particularly in Africa. Well, Dr. Gray, Dr. Beyer, this has been a terrific discussion. I want to just say, Dr. Gray, on behalf of all of our Public Health On Call listeners, how much we appreciate the incredible efforts of you and all the scientists in South Africa, not just around Omicron, but throughout the pandemic. And we wish you the best getting through this, and look forward to brighter days ahead.
Thank you, and stay safe. Wear your mask, social distance, wash your hands, and get vaccinated.
Fantastic.
Couldn't say it better, Glenn. Totally agree.
Public Health On Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media support from Grace Holes Fernandez and Caroline Wong. Thank you for listening.